Good morning, everyone, and thank you so much for joining us. That was a great note to start off on, a great bout of hope, and that's what we want to keep going throughout this conversation. We are talking about building mental health resilience, and there's quite a backdrop of this wicked problem that it's complex, it's enormous. There's so many data points to underscore why we find ourselves in the midst of a mental health crisis. 1 in 5 Americans are suffering from mental illness. It's a huge drag on our economy, costing between $200 and $400 billion a year, depending upon the study that you look at. There's so many data points that can underscore this problem. But we believe that there is a path forward, and we're hopeful. We have Josh is wearing his pin, Hope, at the NIH, so that's what we're going to go with. And we believe that there is great promise in scientific breakthroughs and innovations in care models, mobilization of communities, and the courage of individuals and societies to stand up and speak up about this and help us to get to a tipping point. And we want to think about this problem along the various stages of life, because we know life is very different at age 8, 18, 48, and 78. We have different experiences, different relationships. We're connected to the world in very different ways, and quite frankly, our brain biology is different. So we have a fantastic lineup of speakers for this conversation. All the way to my right, we have Jen Velez, who is EVP of Community and Behavioral Health at RWJ Barnabas, which is the largest integrated healthcare system in New Jersey. We have Cynthia Germanato, who is the president and co-founder of the Born This Way Foundation that she co-founded with her daughter, Lady Gaga. Dr. Joshua Gordon, who is the director of the National Institute of Mental Health, which deploys over $1 billion into mental health research every year. Nora Super, who has that last name for a reason. She's a great colleague here at the Institute, helping to lead our Center on the Future of Aging. And Dr. Howard Spivak, who is the deputy director of the National Institute of Justice, that is the research arm of the Department of Justice. So a fantastic lineup here for the conversation. Before we get started, I want to take a moment and just share with you an effort that the Institute has been working on this fall. If we can pull up slide 3. One of the things that gives me hope at our center is that we have seen a philanthropic response to this problem. We believe that patients need to be at the center of the conversation and the solution. And so this fall, in partnership with the Depression and Bipolar Support Alliance, we administered a survey of people who are living with depression and bipolar. And we asked them about how these illnesses impact their lives, how they're defining wellness, how they would prioritize research activities, and make that available for the funding community. And I have to say that the responses that we got really showed that this community is honest, informed, articulate, and anyone out there watching who took the survey for us, thank you very, very much. We go to slide 4. We're going to share a few highlights throughout the course of our conversation today, but these findings will be shared more comprehensively at an externally led patient-focused drug development meeting with the FDA on November 16th, and we'll have a full report that's going to be available in early 2019. Now we're going to dive into our conversation. So I'm going to go to one more slide, if you can go to slide 5. And we wanted to show what we saw in terms of childhood onset of these diseases. And of the responses that we received, the childhood onset was about 66% of this population. And I think what's interesting here is the further left that you go with the younger of the responders, we'll see that there's a larger percentage of those who indicated that they had childhood onset of illness. And there could be a number of reasons why the data is saying this, but it really underscores that we need to focus on youth. And so that's where I want to start our conversation today. So Cynthia, I'm going to ask you to start us off here, and to help us to characterize the urgency of this issue for youth, and how and why do we need to put youth at the center of the solution?
Thank you for having us and shining a light on this incredible topic. As we know, mental wellness is fundamental and foundational, really, to the wellness of a young person. And we're facing a mental health crisis globally. 1 in 4 of us will experience a mental health crisis. So it's likely that probably each and every one of us and each and every one of you know somebody. 800,000 die by death for suicide globally. And it's the second leading cause of death among young people ages 15 to 29. So, I mean, as a mom and as a parent, this is certainly very scary to me, and as the leader of a foundation, to address this crisis. And, you know, we in particular at the foundation feel that research is wonderful. We're very much a research-based organization, and we have information on thousands of young people about their priorities and perceptions of mental health, but we need to take more action. And we think that we need to do that by really starting with healthy conversations. And you know, an example of that, when my daughter tours, we hit the road with her, and we take our work on the road. We connect young people with community-based organizations where they can go for services, because we're finding that lack of access to quality resources by young people is so urgent. Probably 9 out of 10 young people, based on our research, prioritize quality mental health, yet they don't really know where to go to get support. So we're shining a light on that particular issue.
Great, great. Howard, I want to turn to you next. Throughout your career, you've looked at how adverse childhood events, some traumatic, some seemingly untraumatic, actually can have a long-lasting impact on mental and physical health. Tell us about why we should be so concerned about this, and what is the science telling us about the vulnerability and the resiliency of children?
Yeah, I think that the ACE study, as it's known, is an incredibly important and enlightening piece of work that's still growing and expanding, that at least to this point, unfortunately, tells us more about risk and vulnerability than about resilience. But I think will, over time, teach us more about resilience. But the basic findings from this are that there are a set of traumatic experiences that young children have that have significant implications in terms of their risk for chronic disease, for mental health disorders, for criminal behavior, for unhealthy behaviors like smoking and drinking, and that there's a dose effect in this, that the more of these experiences you have, the higher your risk is. And what's particularly interesting and important is that these are not just events we would typically define as traumatic, such as child abuse or child sexual abuse, but includes things like divorce, parental substance abuse, parental incarceration. So it's a spectrum of things, and it's pushing us to think about this and think about risk and vulnerability much more broadly and in some way a more inclusive way. I just want to add one point, which is that in combination with the ACE study is some work that's suggesting that these experiences may very well have impact, more biological impacts than just neurological. There are studies that are now showing that it speeds up the shortening of chromosomes, and chromosome shortening is a normal aging process. In fact, it's believed to be part of the aging process. But we know that things like child abuse actually may speed up that process, which may partly explain the increased risk for chronic disease, but also raises real concerns about potential generational elements in risk as well.
Nora, I want to move to you next, and you've spent most of your career improving the quality of life of older Americans, and I want you to help us think about from a kind of midlife and older. We know that there are kind of unique complexities, and we're seeing most strikingly an uptick in suicides for those who are 45 to 64. That is a significant indicator of that. How do we need to think about the complexities of life driving that, and how do we need to think about resiliency for these stages of life?
Yeah, you know, as Cynthia said, the rates of suicide as a cause of death are higher for younger populations. But when you go up the age span, some of it is related, obviously, to people who are more likely to die as they get older from other diseases. But there are a lot of things that change over time in all of our lives that I think we can relate to as we get older. When you're in midlife and you know have a job and kids, and many people in mid-career are also caring for their parents now. There's a lot of stress put on them, related to the career. As people get older and reach retirement age, there are a lot of people who lose their sense of identity. They feel a sense of loss there. They may lose their spouse, or many of their friends become an empty nester. So there are transitions in life that affect the way that they have a sense of purpose. Whether or not they're getting help. Many older people have chronic diseases, which is also related to mental illnesses because of having frailty or loss of mobility, and can be a time of loss. But the good news is that a lot of studies look at people that are older, and they're actually happier often than younger people because they don't have as many stresses. So I think there's a lot of hope for resilience in older adults as we look to that time in our life when maybe we can focus on the things that we really care about.
Great. I want to go to slide 6. As part of the survey, we asked people living, again, with depression and bipolar about their research priorities. And you can see here that the top 2 are causation and treatment. So cause, what caused this? Why do I have this? And treatment. And these were consistent across age group, across minority, non-minority, LGBT status, et cetera. Josh, I wanted to turn to you to comment on this. Dr. Collins just spoke about the BRAIN initiative and the work that's underway to help us understand about brain biology. What is most exciting to you around what we're learning about the underlying biology, mechanism of disease, risk factors, et cetera, and how is that translating to what we know about how to prevent and build resiliency?
Well, there are a lot of exciting developments in understanding, in particular, mood disorders over the last, really half dozen years. One of them is in an area that Dr. Collins discussed earlier, which is the genetics. We know, of course, that our genes play a role. It's not the whole story, but a role in the development of these disorders. And we're just now getting to the point where we now have tens of places in our genome that we know are linked to bipolar disorder, hundreds of places in our genome that are linked to depression. This is only part of the story, but the exciting thing is we're also beginning to fill in some of the other parts of the story. So we're beginning to see how things like early life stress alter the way our bodies and brains read those genes out. Mm-hmm. And the hope is that we can put those 2 pieces of information together, actually with the help of some of the technologies that are being developed through the BRAIN initiative, mm-hmm. so that we can get a comprehensive understanding of how genes and environment work to create a risky brain. And then the question is, where we really need more work is on this resilience factor. Mm-hmm. How do you translate that information into treatment? Well, that's a bit of a conundrum. There might be some easy, lucky wins. It might be that through the genes or through the gene-environment interactions, we stumble on some things that we can target. But a lot of that stuff, the exciting stuff that's happening now, won't really turn into treatment for a while. So we have to focus on other possibilities. Yeah. And stress and stressful events is an area where we have a lot more knowledge about. From a sort of basic science perspective that we need to do a better job translating. So we know myriad molecules that are activated by patterns of stress in animals, and some of those have been verified to be activated in humans. Those are the kinds of things that we're looking at for targets, for treatments for depression. But stress isn't the whole story with depression. It's only one of the risk factors, just like our genes are only a part of the risk equation. So even if we use that, we're not sure how far that's going to get us. So there are some novel treatments that are about there, but really what we're doing in the treatment space from a research perspective, just to quickly conclude, is trying to make sure that we can do a good job delivering the treatments that we know work. Yeah. And the most important advance there, in recent times, is the understanding that collaborative care, having primary care doctors work with mental health professionals to attack the full spectrum of problems in individuals who are depressed, because they're not just depressed, they are also at risk for diabetes, they are also having trouble at work and at home, to shore up everything to really help folks.
Yeah, great. great. Let's go to slide 7, and I'm going to ask Jen to jump into the conversation here. But first, I wanted to show this data. We asked, as we're thinking about treatment, and what does it mean for people to be well? How are they defining wellness? And so about 50% of the respondents thought about it in terms of their ability to function. How do they go to work every day? How do they interact with people? About a third think about it as the physical health. How does this manifest physically with them? And then the balance are folks who wanted to improve mood and have a holistic approach that incorporates several of these. So as we're with that as a backdrop and thinking about treatment, Jen, can you pick up on this conversation about what are some of the new models of care, of interventions that you're particularly excited about because of their efficacy or their ability to scale?
Thank you for that, and thank you for the invitation here. I think as a leader in a healthcare system, we really have an obligation to be sure that we're asking the questions, right? So it's not just in the acute care setting where you might be there for surgery, or you might be there for mental illness, in which case you might be a danger to yourself or others, but for the less acute settings, the times where you're your primary care physician, and somebody should be asking you about these very issues, about how are you feeling, how are you functioning at work, what's your relationship with your kids, with your family, is there intimate partner violence? Those are the kinds of probing questions that we really need to be asking our patients, and I really feel that that's our obligation as a healthcare system. And it's exacerbated certainly by the subject of yesterday, the opioid crisis. So we have now family members who are experiencing this kind of loss and disconnection from their family when they see that addiction is ravaging their own family relationships. We have an obligation to ask those probing questions, and we could do so much in the way of prevention by doing exactly that. So prevention with, you mentioned suicide just earlier in the conversation. If we ask the questions and we lose the stigma, I loved yesterday's discussion around stigma, and it continues today. If we can really begin to break down the barriers of stigma so that we're more equipped with our conversations to really ask people these questions, and then we have to be sure that there's a connection for people. I think one of the most effective tools that we can really offer is peer relationships, some kind of a peer connection. We see it now. We have a wonderful Institute for Prevention and Recovery in our health system, which I think has been a model for peer recovery specialists. So I have a lived experience either with mental illness or with addiction, and I can connect with you in a way that somebody else with every best intention has just been unable to do. I think that works with seniors. It certainly works with kids. And then the irony, I think, of another solution is technology. I think it's something that generationally, this is still relatively new for our society, and it has resulted in a really it's allowing people to isolate in worlds that it's really hard to continue to connect with them. However, because of a workforce shortage, particularly in behavioral health, it's also provided some tools to be able to connect. And so if we can figure out how to utilize technology in the most positive ways, we'll be able to ensure that we can keep that connection with that person really alive. So between positive technology interventions and peer supports and really community health workers and other peer relationships, we can begin to build a network so that people don't feel isolated, feel connected. And then you mentioned this integration of primary care with mental health. We have to be able to ask those questions so that, I loved earlier, the brain being a part of the body. We need to ask about that organ.
Yeah, great. So there's a lot to unpack there. I want to ask for the panel to jump in on. So maybe Josh, I'll turn to you. Around this responsibility of asking these questions. We see the headlines: Kate Spade, Anthony Bourdain, and we're surprised. But should we really be surprised? Should we know?
No, we shouldn't be surprised, and it's really important to ask those questions, especially as healthcare providers, although I encourage everyone to ask those questions. Healthcare providers, though, we've shown over and over through different studies, whether it be in primary care or in emergency department, we're not actually all that good at guessing which of our patients are at risk for suicide, for example, and we can identify twice as many people at risk if we ask everybody. Not only that, we know that there are cost-effective interventions when people say, actually, yes, I am thinking about harming myself, that will reduce their risk and save lives. We know this. And so getting those interventions, getting the principle of asking everybody is something that we're really working hard on, trying to get implemented.
Yeah, Howard, I'd love for you to jump into this conversation as well about this responsibility.
Yeah, I think adding to that, I think it's also particularly important to think about prevention in this as well. So not just identifying people at some point as being potentially at risk for acute event, but intervening earlier in childhood and providing things like trauma-informed care, where you identify people who have risk factors of some sort and not only acknowledge that, but begin to think about the kinds of services that may help that individual promote resiliency, moderate those risk factors in some way.
Yeah.
So I think we need to think about what we're doing, not only in identifying risk at every life stage, but identifying opportunities to moderate or change trajectories.
Yep. So Jen brought up technology, and we need to think about technology in order to scale solutions for people there. You mentioned some of the barriers to care and the shortage of human capital to actually help treat. So Cynthia, I'd love to get some of your thoughts on technology, because you've done some research looking at how youth kind of think of how they turn to technology. And there's this irony, right? That some people are saying, well, technology, it's, because of that, we have fewer social connections and we're comparing ourselves to one another. But at the same time, it could be a place that we turn to for comfort and to connect with people. And so what have you seen through your work?
Absolutely. I mean, we know that the impact of technology, it's a complicated issue. It's a very nuanced issue. And we believe that a lot more research has to be done in this area to fully understand it. That said, we also feel that we need to harness it for good, both in terms of combating issues like online harassment, which happen to far too many young people, as well as other people, and also tapping into technology really to provide greater access to care. Young people live online, and they are more prone to things like apps, to looking for researchers. The crisis text line, for example, which allows young people to text for support in time of help, is really something that they are more prone to actually go to. So, I mean, we know that the internet and social media and mobile technology are not going away, so it would really behoove us to take advantage of that.
Yeah, and I read an interesting statistic about this widening gap of care, and especially for young people. If you take all the young people who don't have access to care or not receiving care but should have it, you could fill every baseball stadium on the East Coast twice.
Yeah.
And that's why we need to think differently around how we actually provide help to these folks.
And Melissa, just to jump in there, because I have a 24-year-old daughter with OCD, and she has a therapist that she met when she was in college, and then she moved away, and they still have therapy sessions online, FaceTime, and that's a great sense of support for her because she has someone that she trusts, and as many of us who've had therapists and work with them, that sense of trust and being able to talk to someone that helps you through that treatment is really important. So I think technology can be, as Cynthia said, for younger people, sometimes it has less interaction because of it, but there are other ways that we can really use it for positive effect, where people feel safer too. There have been a lot of studies about famous people, for example, or other people that are afraid because of the stigma that you mentioned, to talk to people about their mental illnesses, and technology can get them help sometimes where they don't have to feel that they have to go into a mental health clinic to get the care that they need.
We're also finding young people, they're actually leading the way in terms of developing some of the apps. There's an incredible sibling team that developed an app called Not Okay that basically, it's kind of like a digital panic button that shows your pre-selected contacts, your GPS location, and when you're not okay, you text them. And it's a way to talk to somebody for support. And similarly, the LGBTQ community is finding a lot of comfort by communities that they're creating online.
Yep, great. Josh, anything to add here? I know you have some interesting technology solutions that you're working on.
Yeah, so there's a lot of research now in things like apps that can be helpful, not just in signaling, acute or delivery of care, but also engaging different groups in active therapies to help improve aspects of their functioning. But there's a wonderful app that's being developed for individuals with schizophrenia who often have social deficits to help them feel more comfortable exploring social spaces. The research needs to be done, though, to demonstrate that these apps are actually helpful, and then policies need to be developed that allow for the payment and reimbursement for these services are being delivered. You mentioned the telepsychiatry or psychology that your daughter's getting by continuing therapy through FaceTime. That can be really challenging from a reimbursement and a regulatory perspective, because these things that cross state lines are problematic. So there's a lot of work that we need to do, and some of it we're doing from a research perspective, some of it we're doing from a policy perspective, but we need both to be able to advance these technologies towards wider adoption.
Yeah. Jen, can I ask you to jump in on this on a policy question? The Mental Health Parity and Addiction Equity Act has been on the books for 10 years. Do we need to do more?
Yeah, we've got a long way to go.
Tell us how.
We have a long way to go. I mean, just actually what Josh mentioned with respect even to reimbursement. So, cancer paid for, mental illness, oftentimes the supports that are necessary to really help address that illness are not. We have a wonderful partnership with Horizon in New Jersey, and they help pilot stuff with us. And that makes a lot of sense, because if we can prove the efficacy of some intervention and then see if we can actually get that paid for, because we've made the case. It's not universal. I think it's really slow going. There's no doubt about that. But we're beginning to, I love when you talked earlier about that study being done by people who are in fact themselves depressed. And in the disability community, the phrase, not about me, without me. So you need to involve the people who are affected, the young people with the app, to develop all of these new interventions and say, this is what works for us. So you could think it's, 2 of these pills and 1 of these shots. That's not working for me anymore. I need a different kind of intervention that actually then the research can prove its efficacy, and then we can begin to change the payment models. I think it's beginning. I think as organizations, any health system, not just ours, moving to risk, being able to say, if I can take full risk of, responsibility for your total cost of care, then I can say that this and that intervention are far better than this other one. So the menu of options to us should be fuller and then much more directed to what actually is effective for your illness.
Yeah, and I want to highlight actually the engagement of a lot of large healthcare organizations in trying to drive the science forward. So we fund a network called the Mental Health Research Network that's a group of healthcare organizations, including Henry Ford and Kaiser, and they're actively doing research in their care populations to show cost effectiveness, to show efficacy of interventions that we've shown work in a lab, but we need to show actually work for healthcare systems.
Jen, I'd also love you to talk a little bit about kind of the impact of social determinants of health on this problem and sort of reinforcing this gap of those who need help the most are not able to get it. How do we break out of that vicious cycle?
So I think the fact that there's even a really increased awareness about the impact of social determinants of health upon someone's self, their full cost of care, their outcomes, is just, it's just enormous. I think what the challenge that some people have is that it tends to be a little fuzzy, right? Is it the fact that you're unemployed? Is that a social determinant of health or housing insecure? The answer really is yes. It's not the list of 10 and the 11th doesn't make it, so it's not a social determinant. It really is kind of the full impact on your life. Poverty is a big piece of it and all the things that flow from there. So housing instability, food insecurity, violence perhaps in your home, a lack of education or less education. I mean, a lot of this is part of your total wellness. And if you look at a pie chart, if we had this up there, you would see that arguably 25, maybe 35% is actually your clinical, well, not that one, but your clinical what is causing you to be sick clinically, and the other 70% is really factors having to do with social determinants. I think the really positive development as of late is that health systems and others, public-private partnerships, are beginning to say we need to care not just for the brick and mortar of a hospital or the primary care physicians, but also the communities in which we're living. So we have some responsibility to help join efforts to develop housing or to buy and hire local, so we can begin to develop a community that addresses those social determinants.
Yeah. So we're talking about some big systems change here. And Howard, I want to invite you into this conversation.
Yeah, I would like to actually build on that, because I think there are individual vulnerabilities around social determinants. There are also community factors. For example, we know the density of poverty in a community has implications for health and mental health. So if you live in a uniformly very poor community, you have greater risk. We know that individuals living in, especially children growing up in particularly violent communities, are also affected. So it's not just their family or them as an individual, but it's their surroundings, their broader exposures that have implications. And I think that's an important guide to health and mental health care, to look at the strategies at the community level, not just at the individual level, to deal with these issues.
Yeah.
Can I just jump in? I just want to say that I think the healthcare community really owes a debt of gratitude to those who are doing this ACEs study, because the fact that that's now getting highlighted really as those life experiences actually impacting somebody's health outcomes, that linkage is just so critical really to help us develop policies.
I agree with you entirely, but isn't it sad that it had to take showing that these risk factors create physical health problems as well as mental health problems for a lot of people to pay attention?
But if they didn't, we wouldn't get funding, right?
But absolutely,
I'm with you.
I agree.
Absolutely.
Yeah.
So we're talking about systems, and Cynthia, I wanted to ask you to talk a little bit about the work that you're doing in the education system, because kids are in school, college, it's a significant part of life, and the foundation has worked to support some programs in schools and in universities. How are you thinking about kind of bolstering what administrators, teachers, have there to be able to support kids from a mental health perspective?
I mean, we're bolstering it by providing tools. We've partnered with the National Council for Behavioral Health on a program called Mental Health First Aid. You're familiar with CPR. I think of this as CPR for the brain. It's a day-long course that allows a layperson really to assess somebody that's in a mental health crisis and talk to them about it and hopefully provide guidance. It's not diagnostic in nature, but it's a wonderful tool. And as I say, it's worth a day of your life to potentially save somebody else's life. The other thing we're doing, though, and I love this conversation about prevention for youth. We have an opportunity to get ahead of this issue. And if you look at the ACEs study, for example, we would like to flip that on its head and do a positive version of that. What are the positive childhood experiences that we can provide to build a generation that's equipped to deal with their mental health issues? So in some of our research, we have found that young people that are in kind environments, they are mentally healthier. And sometimes it's as simple as we found, what are the factors? One of the factors in schools is teachers saying hello to students by name and acknowledging their presence. So what are the things that we can do and rally around young people now that are simple, that are cost effective, that are going to create positive environments for them? The other thing that we're doing from both an education and a campaign perspective is a campaign called #SomeoneToTurnTo. And you can register now through the end of the month for that online. But we believe that most young people, everybody really needs someone to talk to in their life, and many of us don't have that. So this is a challenge to ask everyone, young people in particular, to identify that person in your life that you would turn to talk about mental health, and share that with us on social media. And with that, we provide a resource kit on how to have those conversations, how to start talking about it, and how to be your healthiest self. And our wish is that everyone, everywhere, will have someone to turn to in their life.
If I could just add to that, I think we have to understand that this also has links to biology and neurodevelopment as well, as we know that negative experiences have an impact on brain development and brain architecture and possibly chromosomes. It's reasonable to assume that positive experiences and healthy experiences also have an impact on brain development and brain architecture. So not only is that important in terms of resilience, but it may be important in terms of reversing some of the negative biological changes that occur because of some of the negative experiences.
Great.
Yeah, and I just want to focus on some of the hopeful thing. I think sometimes when we talk about adverse childhood events and you look and several of them apply to you, you think, oh, I'm doomed, there's nothing I can do. And as people get older, there are a lot of community resources that help too. And I know later today we'll be talking about loneliness as a risk factor. As you mentioned, social determinants of health is really becoming better known, but also the linking social services with medical services is an incredible part of that. And making people, helping people and health systems in particular understand that having art classes in your community or creative writing, especially these things that often appeal to many generations, but ways to not necessarily, it's great to identify someone you can talk to about this, but so there are a lot of programs that have shown if you have a gardening club, you have people come together, many of them have mental illnesses, that's not the reason they went to garden, but they get to start to talk to each other and focus on things other than their own problems and trying to make something grow, which becomes a really positive effect. And you can see change as people have. And the last thing I'd say is we see lots of evidence in the aging community that if you have a positive view towards aging, you're more likely to have better health outcomes. So your whole positivity, as you said, it can be just the way that you change the way you think about the world can really have an impact on your health.
Yeah, if I could just add, bringing it back to the school setting as well, one of the problems is that when money gets tight in education, the first things to go are these kinds of things, art, sports, music. And yet they're as important to the healthy development of children as any of the academic work is.
Yeah, Josh?
Yeah, I wanted to speak to the biological issue of this sort of attempt to include more positivity. And it's a curious experiment that really got a lot of wonderful press for a moment, but I think it sort of presages the idea that we can harness this from a biological perspective. So most of you probably know there are these animal models where you can take a rat and you can stress it in various ways, and the rat behaves in some ways as if it's depressed. It's not really a model of depression, but it's a model of the behavioral effects of stress. So a wonderful young investigator, speaking of young investigators before, by the name of Steve Rodriguez, who was at MIT at the time and is now at Northeastern, he took rats and stressed them. And then he was able to find the neurons in the brain that respond to pleasurable experiences through a series of experiments, and then specifically turn those neurons on. So in the absence of a pleasurable experience, just turn those on as if they're evoking memories of a positive experience. And if he played that into the brains of these animals, they actually behaved less like they were depressed. They actually responded to positive reinforcement, positive memories, et cetera. So I'm not suggesting that this would be a treatment for depression someday, but it speaks to the idea that there are biological mechanisms for positive reinforcement, resilient experiences that we can harness if we do the right things.
Great. Can we go to slide 8? I wanted to share with you what we heard from our respondents in terms of how depression, bipolar impact lives. And you'll see here that nearly half of the respondents said that these two illnesses significantly affected them over the last year, and nearly 75% said that they affected them over their lifetime. And I think this just punctuates the point that these are serious and need a significant response. But I want to go back to you, Cynthia, in terms of how do we drive more conversation? How do we get over this stigma? For young people, what are the challenges for them talking about this, particularly between generations, and talking about problems with their parents, and what more do we need to do to really push the conversation for people to be talking about this?
Yeah, I think that's one of the greatest challenge, is remembering that the burden isn't just on the young person to help themselves. I kind of call it the 360 effect, that there are so many of us that are touch points in their lives, whether it be parents, teachers, coaches, whomever that may be. But one is trying to normalize that conversation. I mean, when we have a physical ailment, we generally know who we're going to turn to for that. We've identified our medical doctor, we've identified our pediatricians. What are we doing in terms of being proactive about who we would go to in terms of a mental health crisis? Secondly, how do we help parents and teachers be better equipped to talk to young people? One of the issues that we found through our research is that one of the reasons that young people don't talk to their parents or their teachers is the fear of being judged. Because quite often, because of those intergenerational differences, we want to protect and fix things, and that's not what young people want necessarily. They want to be validated, to know that their feelings are really real and that they're valid, and just have a safe space to express their feelings. So I would say that one is speaking without judgment. Second, with respect to intergenerational differences, I know that I grew up kind of in a time of true grit where my parents were like, snap out of it, suck it up. And they didn't talk about their own struggles. So I think we need to also get better at admitting that we have problems too, and talking to young people about that.
Yeah. Nora, I'd like you to chime in here.
Sure.
You shared with me your personal struggles with depression and the importance of speaking out about it, and with the community. How do we build this momentum?
Yeah, you mentioned earlier the deaths of Anthony Bourdain and Kate Spade, where people said, they were so surprised, they're so successful, they're so happy, they're so gregarious. How could this happen to them? And that really encouraged me to speak out, because I myself have suffered from depression. I've had 3 major episodes of major depressive disorder since I was 35. And I've hidden it because of the stigma. And it's one thing for young people, it's another thing when you have a successful career that you're afraid someone finds out, it's going to impact your ability to grow in your career, what will people think of you, your coworkers, your clients, and so it's really hidden. And as a result, as Cynthia said, when we started, 1 in 4 of us have mental health, so that means at least one of us has it on this stage, as does someone at all of your tables. And I just think we need to talk more openly about it so people don't feel alone, that they don't feel that I can't get over this. For me, it's the promise of recovery and resilience, to be able to say, I've been through this before, I can get better. I think, that's one thing I have learned, and I know the doctors in the room can talk, is the fact that I've had more than 1 episode, the chances I'm probably gonna have another one. So I have to learn ways to cope with it, just like any other chronic illness. And what are my risk factors? What are my triggers? What are the things that I have to do to help to stay healthy? And with that, though, I do wanna say, there's no one cure. I exercise, I do mindfulness, I take antidepressants, I do everything, I'm very knowledgeable about the subject, but there's still a pretty high likelihood I might get depressed again. So I don't want to either have that blame the victim. Sometimes I have this sense that there's, if I do everything right, then, this isn't going to happen to me. And, mental illness, just like physical illness, isn't our fault, as we've, had folks talk about. It's biological, it's environmental. It happens, and so I think people really need to be more open about how they deal with it, how they cope with it, so we can find resilience and recovery.
I think also from an education perspective, we need to get better at understanding the warning signs.
Yep.
I guess a challenge to the medical community, my daughter's depression started in middle school, and as a parent, and if we look at neuroscience, I didn't really understand the difference between kind of normal biological teenage behavior and a real mental health issue. I didn't understand the warning signs. I feel I would have been much better equipped if I knew that. So I think from an education perspective, we can get better at that.
So I'm gonna transition us to our lightning round because we're very near the end. But I'm gonna ask each of you very quickly, because we have about a minute left, what would be your call to action for this group and what gives you hope? And Howard, let's start with you.
Yeah, I think there's two things. One is that we need to invest in and pursue understanding resiliency better. I think that's extremely important and will give us a lot of guidance. And the other is we have to think at a larger societal and community level to change how people think about these issues, that they aren't character weaknesses, they're illnesses, they're chronic illnesses and need to be treated as such.
Great.
And what gives me hope is that we are talking about social determinants of health and the integration of mental and physical health there too. And I would just say from my perspective, you know, it's not easy to come out and talk about the fact that you have mental health conditions because of the stigma. But the workplace, and you know, I'm fortunate to work at the Milken Institute where I feel accepted for who I am, that's whole. So my call to action is really, I think that's a big stressor for people, that if someone finds out it can put my livelihood, my health insurance, other things at risk, is to really accept that this is a part of life and we shouldn't be discriminating against people because they have mental health issues.
Josh?
First, I want to correct it. It's not Steve Rodriguez, by the way. It's Steve Ramirez, just in case you've been searching for that paper and you're all Googling it. You know, I'll echo what was said before. I think the best that the folks in the room can do is, you know, spread the word that mental illnesses are physical illnesses. They're just like all the other disorders that doctors and patients and everyone struggles with, families, et cetera. And ensure that in everything that you all do and advocate for, that equivalence is recognized, because it's really important.
Great.
I would say we need to do more evidence-based research that we can very quickly turn into actionable items to help not only young people, but all of us.
Great. Jen?
I'd say the call to action is to live without judgment, if you can, be much more accepting. So whether somebody has a substance use disorder or a mental illness, if you can live without judgment and help expose some of your own vulnerabilities, we'll have a much more accepting society. And the thing that gives me hope is our young people. I think they really do live with that. They try. I think as a generation, I think more than any of us, I would put myself in the category of adults who have, you know, in the failing category, the young people give us a tremendous amount of hope.
Yeah. Well, to conclude, I actually want to share a few words from your daughter, from Lady Gaga, from her open letter about her struggles with post-traumatic stress. And she says, "I believe the most inexpensive and perhaps the best medicine in the world is words, kind words, positive words that help people who feel ashamed of an invisible illness to overcome their shame and feel free. This is how I and we can begin to heal." And we may not all have large sums of philanthropic funding or research labs or clinical programs, but we all have our words, so we all have a role to play. Thank you so much for coming, and please join me in thanking our panelists.